Price.
Thank you, my lady. Could we please have on screen INQ 304700091? Ms Lamb, this is a report published by SIGSAG on the 13th of October 2021. On page 62 of that, please. It deals with nurse staffing levels in ICU. There is this explanation of the data gathered on this. And it says this is a new section which has been added in order to report nurse staffing levels in ICUs and combined units against agreed standards. These standards are defined in the guidelines. Data relating to nurse staffing are not part of the core data set provided to SIGSAG from units. For this reason, SIGSAG undertook a survey on the 23rd of September 2021, contacting charge nurses who were asked to report staffing levels and unit activity on a single-day shift. All ICUs and combined units with patients admitted with COVID-19 were contacted. Of these 18 units, all 18 responded to the survey. Does it follow from what is said here that beyond this single shift, single day survey snapshot, there is no data available or held centrally about the extent to which ICU and combined unit staffing ratios were in fact maintained during the pandemic in Scotland?
That's correct, yes.
Is that not less than satisfactory from the perspective of understanding the impact of the pandemic on the healthcare system in Scotland?
So I would agree that ideally it would have been really helpful to have access to that data. I think, as you can see from this, the way in which SIGSAG obtained that data was by directly contacting charge nurses and asking them to report on that particular day. I think that the burden of asking them to do that on a daily basis when units were under such significant pressure would have been disproportionate compared to the benefit. But I do absolutely agree that I think there are a number of areas in which it would be helpful for us to have more accurate collection of staffing data going forwards.
The findings of the survey are set out on this single page here. And in headline, in 61% of hospitals, patients requiring level 3 care were being looked after in at least one geographical area additional to the unit's usual footprint to allow separation of patients with and without COVID-19. This required nurses and other healthcare staff to work across more than one area with level 3 patients. 39% of units were able to maintain recommended nurse to patient staffing ratios with ICU trained registered nurses from their own unit. In the remaining 61% of units, staffing ratios could only be maintained with registered nursing staff who did not usually work in the ICU. 67% of units required nurses to work in the unit who were not part of their usual nursing staff complement. And 72% of units were able to retain a supernumerary senior nurse on duty. This snapshot at the bottom paragraph here, this snapshot survey describes nurse staffing on a single day in Scottish ICUs, which will vary over time. However, it demonstrates that over half of ICUs and combined units in Scotland are currently unable to maintain recommended nurse staffing ratios from within their own staffing complement. 2/3 of units are relying on nurses who usually work in other areas of the hospital or urgent nurses recruited through agencies or staff banks. These findings should be considered when interpreting data relating to ICU bed capacity. This is quite concerning, isn't it, that at this snapshot point in time, over half of ICUs and combined units in Scotland were unable to maintain the recommended nurse staffing ratios.
So my reading of this is that they were unable to maintain the recommended staffing ratios using nurses from within their own...
ICU-trained nurses,
ICU-trained nurses from within their own unit, yes. Yeah. So I think what they're reflecting here is the extent to which they've had to redeploy staff who would normally not work in that unit, or staff who would not regularly work in ICU into that place. So yes, and I think that absolutely reflects the fact that our baseline capacity was 173, and we were operating at beyond that baseline capacity.
Were you made aware of the results of this survey at the time?
I can't recall being made aware of the results of this survey at the time. As I've said before, we were seeking to monitor the levels of staffing available across all services in our hospitals. So we were gathering data around sickness absence levels, excuse me, particularly, but also engaging regularly with the HR directors in boards to understand what the level of workforce pressures was on a board-by-board area, and that was feeding into the whole system intelligence work that I referred to earlier.
This snapshot survey having been done, whose decision was it about who should know about the results of it?
So this is a Public Health Scotland publication. So that is obviously those publications are made available to Scottish Government. They're also made available on the Public Health Scotland website. So they're pretty widely available to people.
Okay, so it's just you personally weren't aware of it at the time.
I can't recall this being particularly drawn to my attention at the time. No.
Had it been drawn to your attention, would it have required any action, in your view, on the part of Scottish Government?
So I think that our relationship with our NHS boards is that we rely on NHS boards as far as possible to do what they can in terms of the resource that they have available to them, particularly trained staffing resource locally. And the role of Scottish Government then has to be to look and see what interventions would be helpful at a national level. So, as I've said, we did issue guidance in March 2020 around staffing levels in critical care, recognising that was likely to be a particular issue. We also put in place sort of national mechanisms to try and support staffing. So an example would be the workforce portal, where we encourage people who'd maybe recently retired from services to express an interest in coming back to work, and streamline the process for people to be able to do that through disclosure checks and everything else that's required. We also we also made arrangements to deploy both final year medical students and nursing students. Now, I accept that, that they would have had a limited experience around ICU and critical care, but that was part of trying to make sure that we were able to, I suppose, backfill and support areas of the hospital from which those more experienced staff were being drawn. So, yeah, I think we did what we could at a national level. It remains a situation that the people who work in these units are highly skilled, and it's very hard to create more bodies overnight.
Given that hospitals were not reporting staffing ratio data to CICSAG, how did the Scottish Government monitor the extent to which the staffing ratios were being maintained to standards?
So that would be through the conversations that were happening with the critical care community. So through our sort of direct links into the critical care consultants who lead on a number of those units, but also through conversations with chief executives around the particular pressures that their boards were facing, and as I've said, nurse directors, medical directors, and others. And again, I think one of the features about the system in Scotland is that we do have good, strong relationships and links into all those professional groups. So there would be, where there are issues being highlighted, then the role of Scottish Government is either to see what we can do on a national basis, or to try and broker an arrangement with neighbouring boards around providing support.
Outside of the question of ratios being maintained to standard, that is an ICU trained nurse as opposed to a non-ICU trained nurse, to what extent were you aware of dilution of staffing ratios, that is 1-to-1 becoming 1-to-3, for example?
So I think, for a start, we were aware that would be a likely result of what we were expecting to experience in terms of the numbers of patients requiring ICU. So we had looked at, together with senior nurses and others at what could be done, accepting that, I don't think anybody wanted to be in a position where those ratios were being diluted, but accepting that there are choices to be made there around, whether you're able to treat people or not.
But were you receiving reports of staffing ratios being diluted?
I can't remember receiving specific. I can't recall receiving specific reports around the extent to which ratios were or were not diluted. And I think that relates back to your question around we didn't have a way of centrally gathering that data, which is why this is just a snapshot.
Okay. So does it follow from that even now you don't know the extent to which staffing ratios were diluted during the pandemic?
Yes.
Is there anything that can be done about that state of affairs?
Well, I suppose there's two aspects here, isn't there? One is the collection of the data and seeking to do that in a way that is minimally disruptive. But the other bit is how much capacity you maintain in terms of that ability to scale up ICU quite very quickly. As I've said, these are highly skilled roles, and also roles where if you're not regularly practicing in that environment, then your skills inevitably will degrade. And so I think there's and it's back to the questions about how we would manage a future pandemic and the extent to which some of that is dependent on us having a bit more capacity and resilience in health services than we have at the moment.
Is any consideration being given to how you could collect the data in a way that was less onerous for the particular units?
So we are through a number of mechanisms looking at how we can improve the data that we have around staffing levels in all areas of our provision. In Scotland, we have the safe staffing legislation, which was implemented on the 1st of April this year. And we're also looking to roll out nationally an e-rostering system that will give boards much more granular information around the acuity of the patients that they're looking after, not just in critical care units, and how that matches against staffing ratios available.
Going back to the question of baseline capacity.
Yeah.
Would you agree that looking at the baseline position across the whole of Scotland does not give any insight into variations across the country in terms of how well hospitals were coping with demand?
Yeah, absolutely. I think that's one of the challenges of looking at national level data, is that it can hide things that are going on across different parts of the country. And as part of that whole system information modelling, we had the sort of national level picture, but also a map of Scotland that showed the different boards and that BRAG, so black, red, amber, green, rated them according to a number of measures, not just critical care.
And you'll have seen from figure 22 in the PHS report we were looking at earlier, where there's a breakdown of patients receiving level care against baseline capacity broken down by network. Do you know the figure I'm talking about? There's
Yeah.
We can push it up on the screen. It's INQ 304798816. And we can see here there's it's broken down with those red lines indicating over baseline capacity, and it's broken down into COVID-19 cases and other cases. And we can see at a glance, can't we, that the West network struggled far more with capacity issues than the other, certainly more than the North network and more than the East network. Was that something you were aware of at the time? Yeah,
absolutely. And so we were aware of that because, obviously, the capacity issues linked very strongly to the what we were seeing in terms of the proportion of COVID infections across the country, and also it links to some of the underlying demographics which differ across Scotland as well.
I think you've had sight of a number of territorial health board statements providing data on the number of times between March 2020 and June 2022 that their critical care units reached 100% occupancy. The inquiry's provided you with several of those. Have you had a chance to look at those?
I have, yes.
It's right to recognise that the experience of the health boards is varied, as you might imagine, and there are statements from some territorial health boards that did not report significant capacity issues. But taking just one example of a territorial health board that did so struggle, could we have on screen, please, INQ 304926551? This is a statement provided on behalf of NHS Ayrshire and Arran. So that was the health board that we saw that high point on the graph for earlier. And going to page 4 of this, please. Under the heading of data relating to hospital capacity, paragraph 11 explains that critical care services were provided by both of the board's acute receiving hospitals. Going over the page, please. We see here recorded in this top table level 3 critical care beds and the number of times on which 100% occupancy was reached. Is it your understanding that this is 100% 100% occupancy using surge capacity as well as baseline?
No, my understanding is that this is based on baseline, and particularly if I look at the occupancy, so it's showing that on the 8th of March, both of the hospitals were at 100% occupancy, and that was before we had really triggered the full extent of the surge. So this is my understanding is this is measuring against baseline. Yeah.
So in that table, on my count, there are 9 occasions when level 3 critical care beds in at least one hospital reached 100% occupancy. 2 of these occasions were in March 2020, and on one date, that was the case in both hospitals simultaneously. 5 of these occasions were October 2020, and the 2 remaining were November 2020. And then in respect of level 2 care, the table below, that table goes over 3.5 pages. And on my count, there were 179 occasions in the relevant period where level 2 critical care beds, so HDU, high dependency unit beds, in at least one hospital reached 100% occupancy. And that happened on multiple occasions in each month during this period, save for April to July 2020. On 10 occasions, both hospitals were in this position, and on 2 occasions, both ICU and HDU in a hospital combined were at 100% occupancy. What I'd like to ask is how you and the Scottish Government more widely were kept informed of longer-term patterns like this, of individual health boards struggling with capacity issues.
Okay, so I think the first thing to recognise in relation to this is, as I've said already, this is based on baseline rather than the surge capacity that was put in place. And also, and I think you've probably seen in the statement from NHS Lothian, that it is normal for our health boards to use the facilities that they've got across the whole entirety of their hospital network in order to manage demand, particularly for level 3 and level 2 beds. So there are a number of occasions when there was one hospital, and I don't know whether it was University Hospital Ayr or Cross House, but you know, one of them would be full, but there is still facilities remaining. In the other hospital, which is about 20 minutes, they're about 20 minutes apart. So that's one thing to be clear on. In terms of the trend data for hospitals and indeed more broadly, so that was absolutely one of the things that we were monitoring in terms of seeing increases, particularly in utilisation of ICU. It's one of the things that we were monitoring in the early days, where one of the challenges was not just staff, but actually having the ventilator equipment in place. And we were using that trend data really to assess when we had new ventilator equipment arriving, where that would best be distributed to in terms of where the highest likelihood of that being required was. We also, when I talked about our brag rating, We did that on a trend basis as well, so we would use that to identify whether systems were trending up in terms of the amount of pressure on them, or whether they were level, or whether they were starting to trend down.
When the data that was being monitored was showing a particular board or particular hospitals were under pressure, in that they were regularly at 100% occupancy in at least one type of an ICU unit, did that prompt any further investigation in relation to that particular health board? For example, sending someone out to see on the ground how the hospitals were coping? Because it's not just about there being a bed to put someone in or not. It's about whether staffing ratios were being maintained. It's about the pressures on the staff. It's about the working environment for those staff. So did it prompt any action like that?
So we didn't have a team or an individual who went out, and indeed I think we were quite thoughtful about not putting even more pressure on systems by arriving there. But that said, a number of the clinical advisors who work in Scottish Government also still do clinical sessions. So we would hear direct reports from the front line, if you like, around what was happening in boards. As Scottish Government, I would hear from chief executives in times where they felt they were particularly under pressure, and we would pick up conversations around, what further support could be provided. And as I said, that that's not just around the critical care beds as important as they are, but about pressures more generally across the system. I think that our clinicians in Scotland are incredibly well networked in terms of being able to pick up the phone and support each other as well. So whilst we didn't have a specific team doing that, I think I'm confident that we had really good routes, and each of our boards had their bronze, silver, gold mechanisms of escalating issues within their own systems. Including escalating to Scottish Government through all our regular engagement sessions. Our Cabinet Secretary was still meeting with NHS board chairs on a regular basis as well. So chairs were in a position of being able to raise issues directly with the ministers as well.
I'd like to deal, please, with the permanent ICU bed uplift, which was decided upon in Scotland in 2021. Could we have on screen, please, page 174 of INQ 30485-979? And at paragraph 613 of your statement, you refer to, in April 2021, John Conahan, the COO NHS Scotland, the CMO and the CNO jointly commissioning a short life working group to consider ICU baseline capacity, uplift capacity, and associated factors in preparation for winter 21-22. And you go on to explain what happened after that. What was the thinking behind the permanent uplift?
So I think the thinking behind the permanent uplift was recognising that whilst actually there were not that many occasions when we breached baseline capacity, as you've seen already, there was a sufficient amount of those that we should look to implement a permanent increase to our baseline. And the Short Life Working Group were an expert group who went away and looked at our experience through the pandemic, looked at how that had played out. And it was their recommendation that 30 was the number that we should seek to increase beds by, and that the Cabinet Secretary accepted that, and we then funded that increase so that we now have a permanent funded increase in terms of that baseline capacity.
In the paragraphs which follow, you deal with implementation support for NHS health boards. Were there any difficulties with the implementation of the uplift plan?
I can't recall there being specific difficulties. However, I would imagine that locally there may well have been challenges and delays in recruiting to staff those beds. As I've said, there are not spare intensive care consultants, particularly sitting around. So that is about using the training pipelines that we've got in order to be able to recruit people, and the equivalent for ICU nurses. Although I believe that boards did put in place training arrangements locally as well.
Coming then to third wave capacity issues and response to that. When you gave evidence in Module 2A of this inquiry, you were asked about a period in the third wave from September 2021 when there were higher rates of COVID hospital admissions in Scotland. And is it right that this was linked to the Omicron variant?
That's correct, yes.
You were asked about reports during this time that ambulances could not offload their patients when they got to hospitals because A&E wards were stretched past capacity. Do you recall there being reports of that at the time?
Yes, I do, and I think that was part of the process that we have in place for monitoring what's happening in the system. So yes, absolutely, I recall that being the case as we went into winter 21. Yep.
There had been a permanent ICU bed uplift by this point. Is that right? That's
correct. However, the pressure was not just on ICU. So what was preventing people from being moved through A&E and therefore preventing ambulances from discharging people was not the availability of critical care beds. I can explain the context of that. So the issues that we faced in winter 21-22 were around a significant increase in people in hospital with COVID, not necessarily in ICU, but people requiring hospital treatment for COVID, coupled with an increase in more general presentations at A&E. We'd seen a huge reduction in presentations at A&E during the early part of the pandemic, and we'd got a bit more back to sort of business as usual around that. And also, we had seen an increase, quite a gradual increase, but a sustained increase of the people who were in hospital who were delayed in their discharge. So people who no longer had a clinical need to be in our hospitals, but whose discharge had been delayed largely because they were waiting on social care packages to enable them to return generally into their home. We'd done quite a lot trying to prepare for that going into the winter, but I think the combination of the numbers in our hospitals, and from memory, I think we were running at around about 1,000 people on average, 1,000 beds occupied by people with COVID, and then upwards of 1,500 people who actually didn't need to be in hospital any longer, but were delayed there.
During the pandemic, did you receive any reports of critical care in Scotland being rationed as a result of lack of capacity or resources, whether officially as a policy or unofficially?
No.
Could we have on screen, please, INQ 304775554? This is the guidance issued for the Glasgow Royal Infirmary Respiratory Unit in April 2020. Did you hear Professor Mackay's evidence this morning?
I heard some of it, yes,
some
not all of it.
Well, I'll take you to the key parts. Going to page 8, please. And this is the section entitled Treatment Escalation Plan and Frailty Assessment. And under the heading, there is this guidance. The main complication of COVID-19 disease is hypoxemic respiratory failure, and it is likely that there will be many patients requiring oxygen, some of whom may be considered for increased support, such as CPAP or intubation with mechanical ventilation. Due to the sheer numbers expected, the aim is to establish which patients are for further escalation or not at an early stage of their admission, ideally on admission. Do you read this as implying that it might not be possible to escalate treatment for all patients due to the sheer numbers anticipated in the respiratory unit?
I suppose that could be an interpretation on this. I mean, I think as well that having these arrangements in place are pretty much what what our clinicians do every day, because being mechanically ventilated is not the best option for all people. And obviously, the earlier you can have those conversations, the better. So I think I did hear from the evidence earlier this morning that maybe calling this a COVID-19 specific plan wasn't the best title for it. But yeah, so it. Clearly, we were, I think, based on what had been happening in Italy, we were expecting very significant numbers. As you've seen from the data earlier, we didn't get to the point in Scotland where we breached our surge capacity.
The instruction was that a decision should be made on whether patients were for further escalation or not at an early stage and ideally on admission. And further down, that the decision making on this should be informed by an objective assessment of the patient's overall frailty. And that's the last sentence in that paragraph. Going then, please, to page 34. This is the start of the GRI Emergency Department suspected COVID-19 treatment pro forma. Then on page 37, there's a section of the pro forma dealing with the COVID treatment escalation plan, the emergency department decision, so that earlier stage. And the 4 options there for level of suitable escalation are ITU referral, HDU referral, active ward-based care, and comfort care. And we heard from Professor Mackay earlier that for comfort care, 2 senior decision makers had to agree that, and we see that underlined there. Underneath that, there is a box for communication, and you've heard that the evidence about that, but there was a requirement to record whether the plan had been discussed with the patient or family. And then going to page 42, please. This appears to be the treatment escalation plan to be completed on admission to the unit, as opposed to at the emergency department. And the long box about a third of the way down there says COVID classification and escalation plan. And then there are 2 options for escalation, including diagnostic prognostic uncertainty, review escalation decision daily over the first phase of episode. And then the other option, which is ward level ceiling of care. Then the page after this in the guidance is the clinical frailty scale. And this scores patients 1 to 9. But there's no guidance of how this frailty score should inform decision-making about escalation of care. There is a requirement in that first paragraph we looked at to be considering overall frailty. And this is provided right next to the pro forma, but without any further guidance. Given that this was called a COVID-19 treatment escalation plan, and reference had been made to this sheer number of patients that were expected, do you have any concerns about the guidance in its totality?
So I'm not a clinician, so...
I was about to say that, Ms Lamb. I'm not sure that's a fair question, I'm afraid. Price, sorry.
My lady, understood. There is here guidance that's been given by a particular health board. It's right, isn't it, that there was no national guidance issued to health boards in Scotland on escalation of care and clinical prioritisation. Is that right?
That's correct, yes.
Appreciating that you did not take up the role of DG HSC until January 2021, so you may not be able to speak to the first wave considerations. Was there any discussion at Scottish Government level after you became DG HSC about whether there should be a national guidance in Scotland on escalation of care and clinical prioritisation?
I can't recall there being any discussion about whether we should produce or any intention to produce national guidance on escalation, no.
Does it follow that you didn't receive any reports that there were health boards specifically requesting that?
I certainly wasn't aware that any health boards were looking for that national guidance, and I think our view would generally be that actually it's the clinicians on the ground who are best placed to actually make those decisions based on the individual circumstances and the wishes of the people they have in front of them.
Turning please to the role and performance of NHS 24 and the response to ambulance capacity issues. In December 2020, there was a redesign of urgent care pathways, which saw NHS 24 go from being an out-of-hours service to a 24/7 service. Can you explain the reason behind that change, please, and the aim of the programme?
Yeah, so our programme to redesign urgent care, actually, the thinking around that predated the pandemic and was based on some work we'd done to look at how urgent and unscheduled care was managed in other countries, particularly in Scandinavia, where a number of countries have a process where blue light systems still operate, but actually rather than individuals self-presenting to accident and emergency departments, you phone a number and then you can get appointed to be seen. And we've been looking at that with the pandemic and with the need to try and, as far as possible, keep people away from our accident and emergency departments, both in terms of managing pressures and very often people who present at A&E, there are other routes through which they could be seen, but also trying to avoid overcrowding that would potentially expose people to risk. We accelerated the implementation of that programme. We worked through all the pathways with NHS 24, as you said, taking a key role in terms of providing triage both in hours and out of hours, moving from predominantly being an out of hours service previously. And also setting up what we call flow navigation centres in each of our NHS board areas. That was a process that was tested first in one of our NHS boards and then rolled out to all of them. And the idea there being that it was accompanied by quite a large sort of public information campaign around right place and right time for the right care. And that was about encouraging people, rather than presenting themselves to A&E, to first of all phone NHS 24 and to providing it wasn't an immediately life-threatening situation, and to get advice on what other options might be available. So that might include getting reassurance that they could wait and maybe present either their pharmacist or GP. It might include being appointed into a minor injuries unit, or it might mean being put through to the Flow Navigation Centre, where there would be senior clinicians who were able to advise and sometimes appoint people into A&E, so that we were able to manage that flow of people through A&E and therefore deal with some of the social distancing requirements in a far easier way.
For those who don't know, NHS 24 in Scotland
is our
equivalent
111.
of 111.
Yes, that's correct.
Written evidence from NHS 24 received by the inquiry suggests that NHS 24's additional workforce requirements equated to a 43% increase in staff, and that around 2 million patients have accessed this pathway since it was launched. So this was a significant operational change for NHS 24, wasn't it?
Yes, it was very significant for them.
And the intention behind it was, as you've said, to reduce emergency department self-presentation. How successful was it, this change, in achieving this?
So we think that it has been extremely successful. We have, I think, on average, we've got a reduction of around 10% in those presenting. It's always very hard to say whether you can attribute a change to one bit of a shift in the system, but we have seen a reduction in the number of people self-presenting. And that's coupled with other changes as well. So we also, the ambulance service, have introduced a call before you convey, so that the ambulance service is also, through having that access to senior clinical decision makers, being able to reduce the number of people that they're conveying to A&E as well. And we're continuing, that's a programme of work that we're continuing to promote, that we're continuing to look for improvements, and continuing to develop the way in which we approach that.
Looking at NHS 24 performance against targets, could we go please to page 191 of the longer statement? And this is a table produced by you in your statement setting out performance for April 2020 to March 2021 and April 21 to March 2022. And the target for percentage of calls responded to in under 5 minutes. We can see 4 rows down. There we are in blue. The target's 3 columns in from the left at 50%. And in 20 to 21, we have only 38.4% of calls being answered in this time, and the following year, 25.9%. The target for percentage of calls abandoned after 5 minutes was up to 10%. So that's the row beneath there. And in 2021, 20 to 2021, 13.7% of calls were abandoned in the time frame, and 21 to 22, it was 15.1% of calls. Are these performance results reflective of NHS 24 being unable to cope with the very quick, significant increase in demand which resulted from the pathway redesign, or is it explained in another way?
So if you look at the performance statistics for the first period, so April 20 to March 21, that's the period in which we first implemented the redesign of urgent and unscheduled care. And whilst a couple of the indicators aren't where we or NHS 24 would want them to be, they're obviously more positive than when you look at the following year. So the following year, 21 to 22, that reflects the period when we had the Omicron wave. And as I've said, the services were under, we had more people in hospital with COVID than we've seen at any point before. And that was reflected in the number of calls that NHS 24 were receiving as well. So I think that was really challenging for them. What I would say is that I think one of the other statistics, which is green, is the one just above there, so the care delivered at first point of contact. And that's important because we had shifted with NHS 24 from a performance indicator that was about how fast they answered the phone, so looking for them to respond to calls much more quickly. But what happened then was that they would answer the phone, but then they would arrange for somebody to get a call back. And so that's not particularly efficient or indeed, very person-centred. If somebody's phoning up, then I think they want to be able to understand what they should do next. So that measure there about care delivered at first point of contact is really important, because what that is that people are maybe waiting a bit longer than they would like to get the phone answered, but once they are through and talking to somebody, that person is able to deal with their question at first point rather than them having to wait on a call back.
Turning please to ambulance capacity issues, could we have on screen please page 18 of INQ 30335-968? Paragraph 69, and this is the statement of Paul Bassett again. He deals in this paragraph with staffing difficulties from early summer 2021. And he says, in early summer 2021, coverage of shifts became more challenging due to the compounding effect of a return to pre-pandemic sickness absence levels, while COVID-19 absence remained. This coincided with an increase in demand and wider system pressures across Scotland, for example, increased hospital turnaround times. Throughout COVID, the service used various levels of escalation to ensure that despite high levels of staff absence, high levels of demand and increasing wider system pressures, it prioritised the resources it could generate to the sickest patients. And so, although it would be correct to say that there were no occasions when there were insufficient staff to meet demands on the service, this was only due to the levels of escalation that were put in place to prioritise demand and the additional support received from the military, Scottish Fire and Rescue, and British Red Cross. It was also not without risk to lower acuity patients. How was the Scottish Government monitoring the impact of pressures on the Scottish Ambulance Service, and what steps were taken to support the SAS to meet demand?
So we monitor the performance of the ambulance service through the statistics that they return to us. I think probably at this period we were on daily statistics. I think we're on weekly statistics now. So we're monitoring their response times, but also things like ambulance hospital turnaround times, because clearly that's really important in terms of freeing up ambulances. So we were able to monitor all of that. We had gone into that period, having had discussions with the Scottish Ambulance Service about what further resources they needed, and what further funding they needed in order to be able to extend their capacity. There's a reference there to the military response there. So Scottish Government would have been involved in putting in the official request for what's called the MACA, the request for military assistance. And in terms of hospital turnaround times, as I've explained earlier, the times that hospitals being unable to move people out there, ambulances being unable to move people into hospitals was all aggravated by the sheer occupancy levels in hospitals, some of which was driven by COVID and some of which was driven by delayed discharges. And in relation to both of those features, we had funded the ambulance service to provide additional hospital liaison officers, so people who work with the hospitals to try and support those hospitals to be able to take folk from ambulances. But we'd also, working with local government colleagues, and as part of our winter plan for 2021, had provided an additional investment into social care, for more care at home packages, for more step down facilities where people maybe go to a care home for a short period before being able to go home, and for more multidisciplinary teams to carry out the assessments of those in hospital. So I think we were trying to support both that increase in resource that the ambulance service had identified that they needed, but also some of the underlying issues that were creating congestion for them in terms of how they run their service.
You refer in your statement to the role of the COVID-19 helpline, the National COVID-19 helpline, COVID-19 hubs and community assessment centres in primary care in reducing referrals to hospitals. You also refer to the launch by the SAS in 2022 of the Integrated Clinical Hub. How effective were these initiatives in reducing pressure on emergency departments, and what lessons have been learned from their use?
So I think I've already really covered that piece around trying to reduce the number of people self-presenting at A&E through offering other routes through which people
and
could
these
access
are the
services.
other routes.
Yeah, but the one that I maybe haven't covered so much is the ambulance hubs. And I sort of touched on those earlier. So that was an initiative from the ambulance service to ensure that ambulance crews have access to expert clinical advice and support. And it's that has enabled them to reduce, I think we're on about 50% of call-outs now don't get conveyed into A&E departments, because the paramedics and the crews are able to deal with the patients in their own homes, and to provide support for them, but also link them into local community services. And I think that's been a hugely valuable piece of work, and one that we continue to pursue in terms of identifying whether there are other opportunities. I mean, as far as possible, we need to try and keep people who don't need to be in hospital away from our acute hospitals.
Could we have on screen, please, INQ 30335-968, page 19, please. This is Paul Bassett's statement again, looking at paragraph 73. He says one area which offered a potential pool of additional resource was private ambulance providers. Recognising the potential impact on service demand, the SAS undertook a voluntary review of private providers that indicated they would be willing to support the NHS if required. This review was conducted by a senior manager and primarily based upon the CQC standards as laid down in England. And he goes on that however, Scotland does not have a legislative framework in place for the regulation of private ambulance providers. Consequently, there is no formal agreed governance mechanism by which NHS Scotland health boards, the SAS included, can be assured of the standards that private ambulance providers meet. This includes not only clinical standards, but also matters relating to financial probity, vetting, etc. The SAS therefore does not ordinarily contract the service of private providers. There were limited circumstances in which third sector organisations were asked to provide support. Was any consideration given by the Scottish Government to legislative or policy changes which might have allowed for the use of private ambulances to help meet demand on the Scottish ambulance service during the pandemic?
Yes, so Healthcare Improvement Scotland are responsible in Scotland for the regulation of private clinics, as an example. They do not currently provide. They're not currently regulated for private ambulances. My understanding is that there is now provision for that in legislation, but that hasn't yet been implemented. And it is one of the things that we will look at in 25-26 in terms of the relative priority of starting to regulate and therefore be in a position for NHS services to access private ambulances should that be required. I think, though, as I've said, I think our actions in relation to pressures on ambulances has been more about trying to address the root causes of those pressures, particularly those turnaround times at our hospital front doors, rather than looking to maybe including unregulated providers in that provision.
Coming now, please, to long COVID. You explain in your shorter statement that following a funding call from the Chief Scientist's Office in October 2020, 9 long COVID research projects were funded with a total funding commitment of £2.5 million. Was that Scottish Government funding?
Yes, it was, yeah.
You say that in July 2021, the Scottish Government commissioned NHS National Services Scotland to conduct a mapping exercise of NHS boards to identify how services were being delivered across Scotland to support people with long COVID. The need for a clinical guideline for long COVID had been identified back in September 2020, and there was a guideline in place, a clinical guideline, by December 2020. Can you help with why a mapping exercise didn't take place sooner than July 2021?
So I think what's important to recognise is that the clinical guidance was issued in December 2020, but then that was followed up by an implementation support note, which I think was issued in May 2021. So that was really about providing boards with support and information based on the best evidence that there was around long COVID at that point. So after having issued that implementation support guidance, that was felt appropriate to actually then ask NSS to do the mapping and to identify how boards were in fact providing support to people with long COVID.
In September 2021, the Scottish Government introduced a centrally funded long COVID service in Scotland. Is that right?
That's right, yes.
Could we have on screen, please, INQ 3042178, page 13. This is the expert report of Professor Breitling and Dr. Evans on the treatment of long COVID. And there is this observation at paragraph 28. The provision of long COVID services in Scotland was left to the discretion of health boards for the first 18 months of the pandemic, and therefore there was variation in access and quality. Was it not foreseeable that leaving the provision of long COVID services to the discretion of the health boards was likely to lead to a variation in access and quality?
So I suppose yes, but, and the but is that our health boards operate in very different geographical areas with very different local demographics that range from really big urban settings to very small island settings. And therefore, and I think the NICE and SIGN guidance that issued in December 2020 recognised that there isn't a one-size-fits-all in relation to long COVID provision. And that it was really important. We felt it was really important, therefore, that health boards be in a position to work with their local partners, because a lot of these services need to be provided in the community, and that's where some of our health and social care partnerships and the way in which integration works in Scotland comes into play as well. So it was important for local systems to look to see what would be the best way of providing those services for them. I think after the work that was commissioned from NSS, it was recognised that some central funding would assist boards in providing those services, and that funding has continued, and we've confirmed to boards that funding will continue as well.
Paragraph 29 below says that a report funded by the Scottish Government Chief Scientist Office up to July 2022 indicated that once the public became aware of one of the long COVID services, they were unable to meet demand, and the service closed after 18 months due to lack of funding, with the waiting list distributed to local community rehabilitation teams. Can you help, please, with whether this report of the clinic being unable to cope with the level of referrals once it was set up related to the period prior to September 2021, that is prior to the introduction of centrally funded services, or after?
So it relates to the period prior to September 2021. I think the provision in question was in NHS Tayside, and so NHS Tayside had set up their long COVID service, and they then I don't have any data around the demand for that, but what did become clear to them was that they needed to work more closely with their health and social care partnerships to ensure that they were making best use of services available in the community, and therefore they reworked the way in which they were providing services. So although one approach to the service stopped, they actually set up other approaches to the service, and that then became part of that funded provision.
The National Strategic Network for Long COVID was established in March 2022, is that right?
That's right. I think that the recommendation that a national strategic network be set up was made in, I think, either September or October 21, and that was following on from that work that NSS did on mapping. There was a short life working group. That was then considered by, as we would with any strategic network, it was considered by the NHS board chief executives, who agreed that that would be a helpful enhancement to the services that they were delivering locally, and NSS were tasked with setting that up, and I think that became operational in March 22.
Can you help with why that was not established sooner? Was it simply a case of building on the work of what had gone before, or do you think there was a delay?
I think it was a case of building on the work that had gone before, and also ensuring that we had that NSS and the strategic network would have the best possible chance of success by ensuring that we had buy-in from all the NHS boards, which is a key part of actually having that process agreed by all the NHS board chief executives in one of their regular meetings.
Could we have on screen, please, INQ 305100079? This is a response from the Minister for Public Health and Women's Health, in Scotland to the convener of the COVID-19 Recovery Committee following recommendations that it had made. It's dated the 16th of June 2023. Going please to page 10. Point 173 in the column on the left from the committee was that the committee notes the evidence on the need for long COVID clinical pathways across all health boards and is disappointed to hear that to date only 6 health boards have these in place and 2 more were aiming to have them in place by the end of March 2023. The committee recommends that the Scottish Government works with the National Strategic Network on implementing long COVID pathways across all territorial health boards in Scotland. And then the response to the right was that at present, so the second paragraph there, so in June 2023, 9 boards had long COVID pathways in operation and 5 remained in development. It was noted that where pathways were in development, people with long COVID could receive assessment and input from existing services based on their symptoms and needs. Were you aware that this was the position in June 2023?
Yes, I was, yes.
Has there been a delay in creating dedicated pathways for long COVID?
I think that there has been, I think that certainly those dedicated pathways have been maybe more complex to set up, given the range of physical and mental symptoms that can present as part of long COVID. I am pleased that we can confirm that all 14 territorial boards now have those pathways in place and operational. But yes, ideally, I would have liked to have seen that happen more quickly.
Going please to page 14.226. In relation to comments about the National Strategic Network's work stream on children and young people, the response in the right-hand column was that the Strategic Network's Children and Young People group has been established and met for the first time on the 17th of April 2023. The group's membership includes lived experience representatives from Long COVID Scotland and Long COVID Kids. The group will continue to meet as part of the overall governance structure of the network, and the publication of a pathway for children and young people is in the network delivery plan for September 2023. Do you consider that there was a delay in the setting up of a children and young people's group? And if so, to what do you attribute that delay?
So I would recognise that, given that the work that was already underway in relation to long COVID more generally, yes, it does seem like there should have been work that was ongoing on that prior to April 23. I don't know exactly why there was that delay. I know that the pathway for children and young people has now been published. My working assumption would be, again, around the complexity of understanding what the differences are in presentations around children and young people, and also putting in place appropriate mechanisms to ensure that there is proper paediatric assessment as well, so things aren't being missed through an assumption that this is a long COVID issue.
Moving to data collection on long COVID. Could we have on screen, please, INQ 30468-127. This is a research project briefing from the Chief Scientist's Office from the last quarter of 2023. It deals with deriving and validating a risk prediction model for long COVID. And one of the key findings, the second bullet point under part 1, was that clinical codes for long COVID were rarely recorded in health records. You've seen, I think, the letter that the CMO in Scotland wrote to NHS health boards in February 2022, making the strong recommendation that local primary care teams use these codes to enable development of a better understanding of prevalence over time and to inform the approach to supporting people with long COVID. given that that letter had gone out in February 2022, why, in your view, was there still a problem with the use of clinical coding at this point being reported on in the last quarter of 2023?
So my recollection of the CMO letter was that that was addressed to primary care, and that, you know, really, I suppose the first point of recording long COVID is by GPs in primary care systems. We have GPs use two different sorts of primary care systems in Scotland. And I think that an ongoing challenge for us is to ensure that across, I think, close to 1,000 GP practices, that there is a consistent approach and understanding to the way in which codes are used in those systems. So the letter from the CMO, I think, was to encourage all primary care practitioners to ensure that their staff were aware of those codes and who knew how to appropriately use them. We continue to work with primary care to improve the quality of that data collection and data consistency.
It's important, isn't it? Because it is difficult to give an accurate assessment of prevalence and severity of long COVID in the absence of that data. Is it something that is a priority for the Scottish Government?
So yes, there are a number of areas where we're working with GP practices to try and improve, as I said, both the accuracy of recording and the consistency of recording, because to get a national picture, you need the data to be recorded in the same fields consistently.
And you say you're working with partners on this.
Yep.
What is being done specifically?
So we have a programme for improvement in the data in primary care. And this will be one of the elements that programme of work is looking at. At the end of the day, though, this does rely on individuals being skilled and trained at a very local level.
In terms of reflections and lessons learned in relation to long COVID, it was the evidence of the CMO for Scotland to this inquiry that for future pandemic preparedness, adequate surveillance mechanisms should be in place, monitoring not just the pathogens, but also the longer-term effects of those pathogens to enable planning for healthcare resources in the longer term. Do you agree with that?
Yes, I would agree with that, yes.
Is work being done on that at the moment?
So as I've explained, we are working with primary care and others to try and improve the quality and consistency of our data.
Well, forgive me, setting aside the data for a second, and just concentrating on should there be another situation with a novel virus, is work being done on what could be put in place to monitor the longer term effects from the outset?
So I think that's very difficult until you know what the implications are of that virus are. This is one of the challenges in trying to second guess what a new virus might present us with. I think it's a bit of a trap we fell into in terms of planning for an influenza pandemic, and then what we got was something different. What we need is to have flexibility and capacity within our systems to be able to respond agilely to what is sent to us. And to be honest, that's quite hard at the moment because the system is still under really immense pressure.
And just having taken you away from data, presumably the accuracy of data recording in general terms is important to monitoring of any sort of something.
Absolutely, yes.
Was the potential for longer-term health consequences of COVID-19 given adequate consideration by the Scottish Government and the NHS in Scotland, in your view?
I think that certainly clinicians and others were signalling the potential for longer term implications. My understanding, I think that during quite early, I think August 2020, the Cabinet Secretary was now asked to approve the development of a framework for, we weren't using the expression long COVID then, but the development of a framework to look at post-COVID rehabilitation. And that would include people who'd perhaps been in intensive care during COVID, but also people who maybe hadn't been so ill as to require intensive ventilation, but who were demonstrating other symptoms, whether they be cardiovascular, pulmonary, musculoskeletal, psychological, a whole range. So I think we were alert to the possibility that would need to be something that we looked at. But this was a novel virus, and I think people were still learning about exactly what the implications would be.
My lady, that brings me to the end of one topic. Might that be an appropriate moment for the afternoon break, please?
We shall return at 10 past. I promise you we will finish your evidence today.
Thank you.
All right. Ms. Price.
Thank you, my lady. I'd like to move, please, to shielding and the highest risk list. At paragraph 873 of your statement, in case it helps you to refer, you describe findings of a PHS evaluation of the shielding programme between March to July 2020. A key finding was that in terms of wider lessons learnt for future pandemic planning, a repeat of the shielding programme in its initial format is not recommended. The principle of protecting those at higher risk remains valid. Is work ongoing now to consider how those at higher risk might be protected in a future pandemic?
So I think the things that we learnt from the work that was done around shielding, I think the PHS research also concluded that there were lots of good things around standing up support for people really quickly in terms of groceries and medications and other things like that. But I think, and I think the Chief Medical Officer indicated this, that maybe a blanket approach is not the most helpful one, and that I think in the future, and again, this entirely depends on what sort of future pandemic we have and who are the most vulnerable in relation to that. But I think that the way in which we move towards more of a person-centred approach and trying to ensure that people had enough information to be able to make their own decisions around their level of risk, I think that would be an important. I think the other thing that we absolutely need to do is to think much earlier around the supporting people's mental welfare. So if people are choosing or being asked to shield, then that's quite, it is quite isolating. I think it's very difficult, and the research also indicated that for some people it just was really challenging to be able to do that. So I think we'd want to put in more support earlier. We also, we relied on digital or semi-digital messages, text messages and things like that. So I think we need to make sure that we're not excluding people from participating. We did try through our connected programme to make sure that people had access to digital devices, but I think we probably want to do more in relation to that in the future. So I think that there's been quite a lot. The rapid research that we did around that shielded high-risk group early on in the pandemic was helpful in terms of informing our next steps, and then the further report that PHS produced that could take a bit of a longer-term approach to that has been really useful as well. I think one of the things that's quite difficult for us is that not now having that same contact with that group, and so not being clear about what some of the ongoing issues might be.
Before we come on to that, the PHS evaluation gave rise to a recommendation that future programmes consider more fully the risk of COVID-19 infection during a hospital admission and the support needs of the wider shielding household. What steps have been taken in relation to those two specific recommendations? So taking the first, the need to protect at-risk groups from nosocomial infection, and more generally, that they can access healthcare without fear of nosocomial infection.
So I think I would need to come back to you on that one in terms of what. So we have taken measures around, obviously, and we took measures around having the low risk and the high risk pathways, the red and green areas of our hospital facilities. So that would definitely be part of that. But I think I'd need to come back to you with any more detail on that.
And in relation to the need to consider the support needs of those around the at-risk person, has any work been done thinking about that?
I think in the generality, I think that applies both to the sort of practical support, which we were pretty good at standing up, but I think we didn't give enough, didn't pay enough attention to some of the mental and emotional support for people.
A PHS survey of the highest risk group published in March 2022 found that there was ongoing worrying caution amongst the highest risk group, with 81% of respondents still making decisions mainly influenced by reference to the risk of COVID-19 infection, and 36% still trying to minimise all physical contact with other households. What steps have been taken to act on that evidence?
I think that's really challenging because, as I've said, we don't have the same links into those groups any longer. I think what we've tried to do is to general promotion about encouraging people and to again understand their own levels of risk and provide people with information about whatever it is in terms of their own underlying conditions that influences some of those decisions.
On that particular difficulty in terms of contact, can we have on screen, please, paragraph 910 of the longer statement ending 979? And you say, since the shielding highest risk list ended, SG has no insight into the ongoing challenges and situation for the approximately 185,000 people who were on the list. Scottish Government are aware of the considerable number of people who may continue to restrict contact with others in the outside world. Is that a reference to that survey result we've just been to? And you say currently the Scottish Government has no means of understanding the scale of this issue and how we might be able to support those individuals so that they can start to regain a better quality of life. This is a real cause for concern, is it not? This limitation?
I think that's right. So there obviously are people who, I think, as it notes here, who have a high profile and who actively engage with policymakers. But we don't have a way of sort of systematically addressing all those who might be in this category.
Could there be steps taken for example, targeted liaison with GPs and third sector groups in furtherance of making contact with these individuals, or at least more of them?
I think I would need to take advice from the original shielding division around just how much of that information we retain, given that quite a lot of it was very personal information.
Is that something which is being given consideration or will be?
I would need to check on that.
I'd like to move, please, to non-COVID care, and starting with maternity services. You explain at paragraph 90 of your shorter statement that there are no NHS Scotland national level plans. Sorry, there were no NHS Scotland national level plans put in place specifically for antenatal care, maternity services and postpartum care between notice of COVID-19 first being received and the 1st of March 2020, although there had been some discussion at UK level. Is that right?
Yes, that's my understanding, yes.
In your view, should plans have been in place pre-pandemic to ensure maternity services were prioritised and maintained as an essential service?
So I think that I think that we were always clear about the need to maintain maternity services and also some other essential and urgent services, for example, cancer services, urgent unscheduled care services. So I'm really clear. I think that, again, it's down to, well, what is the nature of the pandemic you face, and therefore what are the adjustments that you need to try to make to the services that you're actually providing.
But as between notice of COVID-19 and the 1st of March, for example, should steps not have been taken in Scotland to put a plan in place?
So I think, as the statement recognises, that there were discussions ongoing at a UK level, and I think the first guidance that was issued came out on the 9th of March. So I think that does indicate that there was work underway, just formal guidance hadn't issued at that point.
You explain at paragraph 92 of your shorter statement that on the 9th of June 2020, as part of remobilisation plans, the Scottish Government's Directorate for Children and Families wrote to all Scottish NHS health boards, heads of midwifery, asking them to return a template outlining the current maternity service provision, including staffing levels and service provision in antenatal, intrapartum and postnatal care. And it was requested that that information be returned on a monthly basis. It's right, though, isn't it, that a decision was subsequently taken that in the summer of 2020 that those returns should be discontinued. Is that right?
Yes, that's correct. That decision was taken in consultation with heads of midwifery and heads of obstetrics in boards, and was taken in light of the fact that boards were reporting that it had taken a considerable amount of effort to respond to that first return, and therefore it was felt again that in terms of the information that we got from that return, that wasn't adding much to what we already knew through direct engagement with all the services.
Well, it may not have been adding very much to what you already knew in that moment for responding immediately to what was going on, but was any consideration given to the value of the collection of that data over in the longer term to understand what had happened?
So I can't recall at that point whether there were considerations around whether we should be collecting that data anyway, if you like, despite the burden that it placed on services, or whether we were in a position to actually document what we knew through the engagements that were happening and what we would then plan to do with that data. A lot of the data that was collected was around the extent to which services were or weren't stood up to their full scale. So the data that we were looking at was really around the extent to which some of the minimum standards that we had set out were being applied, or indeed were being exceeded, because in many cases services were running up beyond the minimum level.
Was any consideration given by the Scottish Government to whether support could have been provided to the services to assist them with the provision of that data to reduce the burden?
I think it would have been, so I can't recall whether there were discussions at that point around what support could be provided. As I say, I think this was and perhaps what we should have done is to think about the template that we were issuing and where it was possible for that to be pre-populated from existing sources of data rather than a sort of starting from scratch data collection.
In the absence of data on antenatal care, maternity services and postpartum care, what did the Scottish Government use to inform guidance and information provided to the public about what level of services was being provided? So
we had set out what were minimum standards for the provision of maternity services, and we also then supplemented that. So, for example, the general guidance around visiting was we supplemented that in terms of whilst one person would be regarded as an essential visitor, we recognise that in maternity circumstances people need to be potentially supported by more than one person, and so we supplemented the guidance around visiting. That was, rather than being based on templates return, that was based on the feedback that we were getting from maternity units. As I said, really regular engagement between the Scottish Government teams and all the heads of midwifery and obstetrics. So they were listening to what were the issues on the ground day to day, and considering where we needed to provide additional guidance to boards to support them. And we were always clear that those were minimum standards, and in relation to maternity services, if boards were able to go above and beyond that and felt that it was safe to do so, then we would expect them absolutely to do that.
Is it right that the result of the decision to discontinue returns is that, other than the incomplete set of returns completed before the decision was taken to discontinue, there is no systematically collected national data covering the delivery of maternity services?
That's correct.
Does it follow that it's not possible now to assess how many women in Scotland were affected by, for example, restrictions on birth location, or whether there were changes in management of particular type of issues?
On a cross-Scotland basis, yes, I think that's correct.
And also whether any specific groups were affected more than others?
Yes, although Public Health Scotland did do some research into the experiences of women who were giving birth during this period.
We'll come on to that in a moment. Looking back, do you think it was the correct decision to discontinue returns?
I think it's really difficult to weigh up the value and to be really clear about the value that you get from returns, again, particularly when those returns are placing additional demands on hard-pressed staff. I think, with the benefit of hindsight, I think that perhaps a way through that would have been to think about what was the minimum data set we required, because the returns were quite lengthy, and to think about what were the things that we absolutely needed, why did we absolutely need those, and what we're going to do with them, and how, as far as possible, could we draw those returns, or could staff locally draw those returns from systems rather than, having to sort of fill them out from scratch.
It's right, isn't
Sorry
it?
to interrupt. I think too, one has to remember, and you said at the beginning, I think, of your evidence, or somebody has in relation to Scotland, one has to remember that with a smaller population and the group of people, as you said, around a table, whereas for England, you may not find out what's going on in Cornwall or Norfolk or Manchester. For you, it's much easier to get the information without having the data returns.
Yeah, Milady, I think that's absolutely the case. We are a small enough system that, as I've said, there were, I think, really regular, sometimes daily meetings between the heads of midwifery, heads of obstetrics with the Scottish Government team. So they were hearing what was happening on the ground. And one of the reasons for standing down the data collection was because they felt that it actually didn't add anything to what they were already hearing. So whilst technically, I suppose it means we don't have a nice suite of reports going through monthly, I don't think that means that we didn't have a good understanding about what the situation actually was.
Sorry to interrupt, Ms. Brace.
Not at all. Thank you, my lady. It's right, isn't it, that one of the key changes in the provision of maternity services in Scotland was to limit face-to-face contact between expectant mothers and healthcare staff as much as possible to reduce transmission risks? Yes,
that's right. I think it meant that as far as possible we moved to using online means for consultations between pregnant women and staff, and also standard antenatal classes that would normally be face-to-face with groups of expectant women were stood down as well because of the risk of infection.
Was any advice sought about the negative healthcare impacts of a reduction in face-to-face care, including, for example, on the mental health of new mothers or those who had experienced baby loss?
I think that when the team were looking at the relative benefits, the concern around the spread of virus and the concerns of mothers themselves around the spread of virus outweighed the potentially negative risks. I think that obviously we tried to ensure that mothers were provided with an equivalent level of support. So, for example, we used an online antenatal class, but absolutely accept that that is not the same as being able to be in a room with other people and to interact and to share experiences and form ongoing relationships through that. So I think that we would all accept that those interpersonal relationships were impacted in many areas of healthcare, but perhaps particularly in maternity services. And certainly, I think for learning for the future is being able to is how we can somehow, whether that be running group sessions online or how we can try and mitigate against some of those negative effects.
The inquiry has heard evidence that it was a case often of least bad decisions and that this was all a difficult balance in terms of making these decisions. But when the decision was made to reduce face-to-face contact, were those impacts actually considered at the time in that balancing exercise?
So I think wherever possible, we were trying to balance off the negative impacts of decisions, and you'll already have heard about the four harms approach that we adopted in Scotland. But I think that quite often, because of the nature of the virus and the rate at which it was spreading, then the overwhelming concern was to put in place protections that would stop people from catching the virus.
You deal with guidance on visiting in maternity and neonatal settings at paragraphs 113 to 116 of your shorter statement. This guidance was initially included in the general COVID-19 hospital visiting guidance, but in July 2020, service-specific guidance was issued to maternity and neonatal services on person-centred visiting in those services. Is that right?
Yes, that's correct.
And what prompted that change?
I think there was a concern, and no doubt that was coming from what I've described as the regular meetings with people in the boards, that the guidance around visiting was being interpreted on a side of strictness as it applied to maternity, and therefore the sort of essential visitor was being defined as people just being able to have one person with them, and potentially not the guidelines on more general visiting not permitting somebody to be accompanied to antenatal appointments. So we felt it was important that we clarify the expectations around women being able to be accompanied to antenatal appointments, to being able to have an essential visitor, a designated birth partner, but also someone else, and in certain circumstances more than one person. And also then, in neonatal units, for example, parents not being defined as visitors, but being able to access those units. So that guidance was indicated, I think, to absolutely clarify that was the position for all of our boards.
Given the particular considerations which apply to maternity and neonatal services in particular, do you think that the guidance should have been service-specific from the outset?
Yes, I think that it would have been helpful had we issued that guidance right at the beginning and have it had specific sections around visiting that applied to maternity and neonatal services.
A report was published in April 2022 following the COVID experiences of pregnancy study. Is that what you were referring to earlier?
Yes, yeah.
Yep. And that was commissioned by the Scottish Government in 2021?
That's correct, yes.
A headline finding of that report was that COVID-related rules and restrictions for maternity services were perceived as poorly communicated and inconsistent across different services and centres in the maternity pathway. And one rule in particular was highlighted as a major source of anxiety, and that was women not being allowed to have a partner attend maternity services with them. Do you recall the section of the report I'm referring to?
Yes, I do.
Has the Scottish Government implemented the recommendations made in that report?
So I think that the recommendation around poor communication and also variation in what was permitted in different boards, the guidance that we issued in July was intended to address that and to absolutely acknowledge that we expected that boards would permit pregnant women to be accompanied to antenatal appointments. And indeed, the other things I've mentioned around having more than one essential visitor.
What learning has been identified by the Scottish Government, whether from this study or more widely, about reduction in face-to-face contact in the context of antenatal, maternity and postpartum services and visiting restrictions for maternity and neonatal services?
So I think, firstly, if we were in that position again, then we would want to ensure that we were issuing guidance around visiting that was specific to maternity and neonatal services right at the beginning, when we're at the same time as we're issuing visiting guidance around anything else. And I think that we would, I think that would help in terms of that clear communication, being really clear with women what their expectations should be. And also addressing some of the issues around variation. So we need to be really clear that this is an absolute minimum. I think in terms of the face-to-face, I think we've all recognised that whilst digital solutions had a really important role to play, there are circumstances where actually that people being able to talk to others and to communicate and share experiences is really important. So as I've said, I think that there are areas where if we were again in a position where it was very difficult to allow groups to come together in that way, face to face, as you would for a normal antenatal class, that we would want to look and see whether there were ways in which we could facilitate that online, so it wasn't just one-to-one. We were able to do group sessions.
Moving, please, to the clinical prioritisation framework for elective care, which was introduced in November 2020. Could we have on screen, please, INQ 30357-276, page 56, please? This is a section from a Public Health Scotland report on inpatient, day case and outpatient stage of treatment waiting times. And the background to clinical prioritisation is provided here in the first paragraph. So in November 2020, this clinical framework, coronavirus, COVID-19, supporting of elective care, clinical prioritisation framework was introduced. It was an interim measure to provide NHS Scotland with clear guidance for prioritising elective care whilst ensuring appropriate COVID-19 safety and priority measures were in place. And it's explained that this was at a time when elective care capacity was severely constrained by the pandemic and the backlog of patients requiring treatment was beginning to grow. The framework became no longer applicable on the 22nd of July 2020 when it was stood down by the Scottish Government. How was the framework used to prioritise elective care?
So the table that's on the
If we scroll down a little, please.
Right. So the table there is essentially the prioritised framework. So this is based on clinical judgment in terms of people, clinicians reviewing the lists of people who are waiting for treatment and categorising them in terms of the relative urgency of this. You can see that priority level 4s are down as being safely scheduled after 12 weeks. So that would be absolutely, the non-urgent surgery. And although it might be non-urgent in a clinical sense, that doesn't mean that it isn't something that is impacting on somebody's quality of life. So this framework, I think, and you see it was developed by the Federation of Surgical Specialty Associations. So it's looking across all specialties. But we, so this was introduced in terms of trying to ensure that the resources that we were able to stand up around elective care were focused on those with the greatest clinical need. And then the framework was stood down in July 2022, I think, on the basis that recognising that what although we had been dealing with those who were clinically most urgent, that had meant quite an increase in people waiting very long times. And we wanted to ensure that that clinicians had the flexibility to be able to both treat people who were immediately urgent, but also to start to address some of those long waits, where people were obviously experiencing detriment to their quality of life.
Just dealing with those timings,
Yeah.
the introduction in November 2020, why was it not until November 2020 that this was introduced? Appreciating
yeah.
it was before you were DG.
Yes. So I maybe can't be absolutely exact on this, but I suspect that this was because I think that we had maybe certainly, I think when we came out of the initial wave of the pandemic, I think we maybe over-optimistically thought that we would be able to get services back to normal much more quickly than actually we were able to. So as we started to recognise that not only was COVID with us to stay, because we're still experiencing COVID right now, but also that we were going to continue to experience waves of COVID, then we needed to think about how we were going to take a different and consistent approach across Scotland to elective care.
You've referred to the reasons why it was stepped down in July 2022. Did the decision to keep it in force until then remain under review?
Yes, I think all our decisions around this remain under review, and it's again, it's one of these sort of decisions are the sort of things that are discussed regularly in terms of all those groups that we have meetings. So this would regularly come up amongst the Scottish Association of Medical Directors, for example, in terms of, is this still an appropriate way to be looking at things? And it was, I think, as a result of some concerns about the number of long waits that we were building up, that ministers took the decision to actually step down this and to allow greater flexibility at a local level.
Has any work been done on what the longer term impact of the framework was, whether positive or negative?
I'm not aware of any work on the impact of the framework. Clearly, waiting times and the categorisation, both of our lists against the priorities, but also in terms of numbers of weeks waiting, is ongoing work.
You identify a number of lessons learned in relation to non-COVID care in your shorter statement, from paragraphs 255 to 258, if that helps you to refer to them.
Okay.
Can you summarise briefly, please, what those are? And do refer to those paragraphs if you need to.
Thank you. Find them. It's right at the end, isn't it? Yeah, so I think there are a number of things there. One is around us, and I think that's reflected in the prioritised framework we've just seen, that we need to ensure that we are taking advice from the Royal Colleges and other clinical experts in regard to how we prioritise tests and treatment. We also talked about supporting shared aid across NHS health boards to maximise available capacity and to minimise backlog growth, and that's certainly something that we're very actively pursuing, or have been actively pursuing, in terms of how we can best direct the capacity that we have available and how we can use our national treatment centres, for example, in order to make progress on waiting lists. That includes people travelling, so travelling out of area, as we would call it. So people may be treated at a hospital that is not in their board area, but a hospital that has the capacity to do that. And then we also talk about protected sites, so keeping effectively green sites for cancer treatment, and some of the issues around redeployment of staff. So, yeah, I would recognise all of those.
I'd like to ask you next, please, about the impact of the pandemic on the NHS workforce and staff support and wellbeing. You deal with pandemic-specific support in your longer statement, at paragraphs 327 to 336. And you deal there with the various forms of support which were made available to the health and social care workforce. The first of those forms of support, a national wellbeing hub, being launched on the 11th of May 2020. Is that right?
Yes, that's correct, yeah.
A national helpline was launched at the same time.
Yeah.
And in August 2020, a workforce specialist service was established. Is that right?
Yes, I think actually the approval to establish that was in August 2020, but because it was a specialist service, it took a little bit longer than that to be actually up and running.
I see. What type of service was this, the workforce specialist service?
The specialist service was designed to offer psychological support and counselling to staff who had been impacted, particularly by the pandemic, but who might feel uncomfortable seeking support from within their board area, or either talking to their clinicians who might just feel a little bit uncomfortable seeking support in their own in their own system, essentially. So it was established to offer a service that was separate from the general NHS provisions.
And in September 2020, the Scottish Government provided funding to assist health boards in delivering psychological interventions and therapies. Is that right?
That's right. So as well as establishing that specialist service, we also provided funding to enable boards to increase their capacity to provide therapies to their own staff as well.
Funding for practical support also followed. Can you give an example or some examples of what practical support looked like?
Yeah, so I mean, really pretty basic practical things like ensuring that everybody had access to hot drinks, hot food, that there were rest and recuperation areas so that people could get away and get a bit of downtime when they were on pretty arduous shifts. So that was funding that we provided, and have encouraged boards to continue to make sure that staff are well supported in those sort of ways.
Then in 2021, there were 3 separate injections of funding from the Scottish Government for practical and wellbeing support. Is that right?
That's right, yes.
You deal with measuring staff wellbeing starting at paragraph 342 of your longer statement.
Yep.
And one step that was taken was conducting the NHS Scotland Pulse Survey, which was launched on the 1st of September 2020. What were the key themes arising from the results of the NHS Scotland Pulse Survey?
Yeah, okay, so it's maybe just in context worth saying that in Scotland we have a pretty well-established staff survey called iMatter, which runs every year. The Pulse survey was agreed in partnership with staff side, with our trade union representatives, as a way of getting a sort of much quicker view on how things were with staff. So I think that there was a fairly short number, maybe about 8, I think, quantitative questions, and then staff were also asked to identify what they'd found particularly helpful and what had been most challenging for them. In terms of some of the themes coming out of that, first of all, I think we got a really good response rate. 43% of staff took part in that, and it wasn't just across our NHS boards, it was also extended across our health and social care partnerships, so it covered staff working in social care as well. In terms of their concerns, largely staff were concerned about their ability to deliver high quality patient care. They were concerned about their safety, the safety of their families, and it's almost surprisingly their work experience at work didn't show a huge drop from the previous iMatter scores. They also acknowledged that they'd been through a significant amount of change, and there was a lot of emphasis placed on the value of local support within boards.
You refer in your longer statement to the Directorate for Population Health's report published in August 2021, Lessons Learned from the Initial Health and Social Care Response to COVID-19 in Scotland. Could we have on screen, please, page 279 of that longer statement? And in the middle of the page, these are the report's findings about opportunities for further resilience in the context of well-being. And is that healthcare staff well-being?
Yes, that is healthcare staff well-being, although I would say that applies equally across to social care staff as well.
And the opportunities which were recognised with ease, recognising that well-being response to the pandemic will be needed in the long term, leaders must consider how to transition this into business as usual and continue to support the physical and psychological well-being of staff. And then line managers continue to be a source of support to staff. Leaders should consider how to equip managers with the necessary training and resources on how to support staff remotely. What steps have been taken by the Scottish Government in furtherance of those recommendations?
So obviously what we put in that, we put in the original funding. We also worked with boards to appoint wellbeing champions across our board structures. And we have recently, in the last year or so, we've stood up our leadership culture and wellbeing board, which looks at measures of leadership culture well-being across boards and brings forward recommendations for work that we should continue to do. Because I think as this recognises, this isn't just about that immediate response to the pandemic. I think it's also very much about valuing our workforce, about having cultures in place that value and support our workforce. And that's really is and will be very important to us as a system going forwards.
When the Chief Medical Officer for Scotland gave evidence to this module of the inquiry, he told Her Ladyship that he considered the Scottish Government was too slow to provide support to the NHS workforce. In particular, he thought that psychological support and safe spaces for staff to debrief should have been provided sooner. Do you agree with that assessment?
I think that we probably need to separate out the responsibilities of Scottish Government from the responsibilities of NHS boards who actually employ the staff and have that duty of care responsibility for staff. What Scottish Government tried to do was to step in to provide funding support to ensure that boards were able to provide that sort of capacity. But I think there are lots of good examples of where boards themselves had already recognised that there was a need and were already providing that. Scottish Government provided the funding for it, and we continue to work with boards as part of our staff governance standard to ensure that they've got good strong leadership, good strong cultures of valuing and supporting staff.
You have at paragraph 940 of your longer statement set out a range of other lessons learned identified in the Directorate for Population Health's August 2021 report. Those go much wider than the wellbeing questions. I don't intend to take you through all those now, although I would refer anyone who is interested to that paragraph in the statement. Just this, though, do you agree with the learning points identified in that report set out in your statement?
Yes, I think there are a number of themes there. So that report was produced, I think, based on the first 6 months experience in the pandemic. I think that we would recognise most of those points, and it's clear that you can start to bring those recommendations together into themes.
Finally, I'd like to ask for your views, please, on the reflections given to the inquiry, again by the Chief Medical Officer for Scotland, about the impact of the structure of the NHS in Scotland on the healthcare response to the pandemic. In his evidence, Professor Sir Gregor Smith highlighted the lack of an equivalent to NHS England in Scotland, suggesting that a once for Scotland approach was made more difficult by the absence of a national entity to oversee the healthcare response to the pandemic. Do you agree with him?
On this occasion, no, I don't agree with the Chief Medical Officer. Very rare for me to disagree with him, but on this occasion, no. I think, as I explained right at the outset today, we do not have a legal entity called NHS Scotland, but what we do have is very, very close working relationship. So in my job, I wear one hat as the Director General and I wear another hat as Chief Executive of NHS Scotland. Wearing my Chief Executive of NHS Scotland hat, I have a very direct relationship with all the Chief Executives of our NHS boards because I delegate their accountable officer status to them. And more generally, I meet with them on a monthly basis. We do our best to ensure that we are aligned in terms of planning and delivery so that they absolutely understand the priorities of ministers and that they're then able to provide me and my colleagues with assurance about how they're going about delivering those priorities. So I think we've got a really strong loop and feedback loop in terms of being able to advise ministers around some of the challenges and delivery. That helps ministers in terms of their setting of strategy and policy and then leads back into ensuring that that strategy and policy can be implemented and delivered and the performance management that goes alongside that. And as to Once for Scotland, so we do adopt Once for Scotland approaches. When we do that, that is an approach that is agreed with the chief executives and therefore is an approach that we're all signing up to. We have been running an NHS Scotland Planning and Delivery Board for about 18 months now with the express purpose of ensuring that where things are best taken forward on a One Service for Scotland approach, that is exactly what we're doing. I think it's also important to note the roles of ministers here. So ministers, the Cabinet Secretary for Health and Social Care meets with our chairs of NHS boards on a monthly basis. As my lady's indicated, we are of a size where those relationships can be very strong. And we use those relationships a lot. It's also the case that ministers have the power to direct NHS boards. So should we be in a situation where there is something that needs to be done on a Once for Scotland basis and for whatever reason NHS boards aren't responding to that, ministers have the power to direct that.
My lady, those are all my questions.
Thank you very much. I think we now go to Miss Munro.
Thank you. Good afternoon. My name's Alison Munro. I ask questions on behalf of COVID Bereaved Families for Justice UK. I just have two very short questions, please. During the course of your evidence, Mrs. Lamb, you've told us about certain areas where Scotland diverges from the UK in terms of the path they took during the pandemic. One of those areas was in relation to field hospitals. In your statement of the 18th of June of this year, you explain how in Scotland you looked at what was happening with the Nightingale hospitals in England. And as you say at your paragraph 697, my lady, for the record, it's INQ 000 485979, that in order the decision to establish NHS Louisa Jordan Hospital was based upon not a decision to expand ITU capacity, but to provide a facility for non-critical patients. You also say at paragraph 700 of the same statement that there was an awareness quite early on that in terms of, and you looked at the staffing picture nationally in Scotland and also the data from the portal called Turas, I think.
That's right, Turas, yeah.
Turas, I know I'd pronounce it incorrectly, which is NHS Scotland's digital platform, I understand.
That's right.
That, quote, there would be difficulties with fully staffing a large field hospital like the Louisa Jordan alongside the existing estate. Now, that all said, what additional pressures did the establishment of the Louisa Jordan Hospital place upon existing hospitals in the estate and health boards?
Okay, so the decision to establish the Louisa Jordan, as you've correctly identified, was not to set it up as an intensive care facility, because I think, as we've already heard, the evidence around boards having to manage on a larger geographical footprint were already creating pressures, and to have establish yet another geographical facility somewhat remote from our existing hospitals would have exacerbated those pressures. So our original plan for the Louisa Jordan was that it would be used for the care of people who were not critically ill, perhaps people who had been but who were recovering. In actual fact, we never needed to use that. We had enough capacity within our general hospital base, so the Louisa Jordan was never used for that. We did use the Louisa Jordan for outpatient clinics, so we used it for outpatient clinics for orthopaedics, I think gynecology as well, and we also used it as a training facility, so it was really helpful in terms of having that available. We used it for, I think, the Scottish National Blood Transfusion Service used it, and we used it for a vaccination facility. So because we never got into needing to use that for very ill patients, albeit not critically ill, it didn't place pressure on our other hospital staffing complements. And where we were using it for outpatient clinics, that was really around providing an environment that was COVID-free. So it was for staff were able to move their clinics, if you like, to a different location. And obviously the vaccination programme was a huge use of it as well.
Thank you. And the second question is this. Still on the field hospitals, I mean, there have been criticisms levelled at field hospitals, some of which in the UK and England were very much underused. The criticism levelled is that effectively they were very expensive white elephants. And you, in your statement, the second statement, paragraph 713, you identify and recognise that there were question marks about the Louisa Jordan Hospital and whether or not it was delivering value for money and or whether it was necessary in terms of provision of healthcare in Scotland. So in terms of lessons learned, what has been done by the Scottish Government and the Directorate to look at improving resilience and preparedness in the event of a future pandemic, to ensure that if these field hospitals are required again, that A, they have a full complement of staff, and B, that they actually can be utilised effectively?
Yeah, thank you. So the decision to establish the Louisa Jordan in the first place was I suppose, based on what we observed happening in other countries and the modelling that we had available to us at that time. So it's hard to say would we have made a different decision looking at that same modelling now, but with the benefit of hindsight, when we know that actually that modelling didn't play out to reality, then yes, you do think, well, had we known that that was the way that the pandemic was going to develop, we might have made a different decision. In terms of going forwards, I think we need to be mindful that the NHS is not an organisation that has lots of spare capacity sitting around, and therefore we need to make sure that the capacity that we have is being used as appropriately as possible. So the measures that we've already been taking around redesign of urgent care, so that only those people who really need to go to hospital for urgent care arrive at urgent care, and the measures that Scottish Government have been taking to improve and enhance social care, so that people who don't need to be in hospital are not left in hospital when they no longer have a clinical need for that, and also that our social care services need to be strong enough because they have a real role in preventing people from being admitted to hospital in the first place. So I think our focus at the moment is very much on how we best use the capacity that we have in the most appropriate way, in a way that enables people to be cared for in the right place for them, rather than thinking about standing up facilities that we may or may not need.
Thank you very much, Ms. Lamb. Thank you, my lady.
Thank you, Ms Monroe. Ms Sivakumaran, at the back there. But if you can make sure your answers stay in the microphone, it'd be great.
Thank you.
Good afternoon. I represent the long COVID groups. My first question touches on the impact of long COVID on NHS Scotland healthcare workers. At paragraph 51 of your witness statement and in your evidence this morning, you have said that you have data on healthcare worker deaths and data on staff absences. You've also explained that there is, whilst there's data on absences due to COVID-19, you don't know if that's because healthcare workers had COVID-19 or if they were, if it was because a family member was infected and they're quarantining. Does it follow that there are no records of staff reporting the long-term effects of COVID-19, that is long COVID?
So that is my understanding, yes, that the coding within our staff time system groups together the COVID absences, and that those COVID absences could be as a result of long COVID, could be as a result of people having COVID, but also equally could be as a result of family members having COVID and therefore people self-isolating. That is in the national statistics. There may be intelligence available, more intelligence available at a local, an NHS board level, where our expectations would be that, and I think you heard some of this from Professor Mackay this morning, that staff with long COVID are being supported, ideally to return to work in the way that we would expect any member of staff in a long-term absence to be supported. But I don't have access to that data on a national level.
And so it follows you haven't requested from the health boards whether they hold data on the number of staff that have long COVID?
I'm not aware that we have requested that, no.
Do you agree that it would be useful to know nationally how many healthcare workers are affected with long COVID?
Yes, I do.
And you've also mentioned this afternoon that COVID is with us to stay, and because we're still experiencing COVID right now and are going to continue to experience waves of COVID-19, would it be fair to say that along with new waves of COVID-19, patients and healthcare workers continuing to be affected with COVID-19 may develop long COVID?
Yes, that is my understanding. I'm not aware of what the more recent research is in relation to the success of the vaccination programme, particularly in terms of protecting people from long COVID.
But it follows that you're not taking steps to monitor any of those new cases of long COVID.
So I think I would need to go back to NHS boards and establish whether the extent to which we're seeing new cases of long COVID coming through.
Okay, thank you. My last topic is on support for healthcare workers with long COVID. A CSO research project briefing that you have exhibited to your statement reported on the experience of healthcare workers with long COVID in Scotland. That's the LOCK study. The URN for reference purposes only is INQ 30468-129. Now, this study found that most participants were in work in the NHS, but managing complex and dynamic symptoms with periods of improvement and exacerbation. It also found that 17% of participating health workers were so severely disabled by long COVID that they were not able to return to work. What support, if any, is there available for healthcare workers suffering from long COVID?
So I think the support that is available will very much be at a local board level in regards to the board's responsibilities as employer of those staff, and again we would expect all boards to be regularly engaging with staff who have been off work for any time or who are experiencing difficulties and perhaps having multiple experiences of absence as a result. But we don't have that data centrally.
And there's been no review at a national level of consistency across the boards of support for healthcare workers?
Not that I'm aware of.
Now, the CSO research report also refers to NHS long COVID payments, which ended in October 2022. And the report states that the NHS long COVID payment had been fundamental in enabling participants to work in a reduced capacity without reduced pay. But there were high levels of anxiety about when the payment would stop and the implications for them and their family financially. And it continues that the reduction in pay and job security would have resulted in additional stress and anxiety for those unable to meet their contractual obligations. Was there any dedicated financial support for health workers with long COVID after the NHS long COVID payments ended?
I'm not aware that there were. I think the NHS long COVID payments were an extension to our normal occupational sickness policy, so it enabled people who were unable to work to continue to enjoy their salary for longer than would normally be the case.
Okay, thank you. Those are my questions, my lady.
Thank you. Mr Wagner. Mr Wagner's over there. Oh, there he is.
Turning on? Is that, yes. My name's Adam Wagner and I ask questions on behalf of the clinically vulnerable families. I want to ask you first, please, about the non-shielding at risk category of people that you refer to in your statement. I'm just looking at paragraph 824 of your longer statement, where you say, in addition to the shielding list, there had been consideration early in the pandemic to other people at risk, and these were the non-shielding at risk. People in this group were not individually identified, but were encouraged to seek help via a helpline, which channeled calls to local authority help services should they not have family or existing community support or not have access to the online support. Do you recall that category?
Yeah, so I recall the work that was done. I think this must have been early summer 2020, in partnership with local government, recognising that there would be people who were not officially on the shielding list and therefore were not in receipt of the support, groceries delivery, etc., but who might be vulnerable and might not have family members to support them. And therefore we worked with local government to try to ensure that those people had access, as it says, to a helpline, and were able, the local government colleagues were able to then support them.
So we now know that a significant proportion of those who ended up dying or suffered adverse effects from COVID-19 were part of that non-shielding at risk group. It makes sense because they would be particularly at risk of COVID, but not deemed to be clinically extremely vulnerable. Do you think, looking back, was enough done to inform that group of their heightened level of risks and the step that they could take, or others around them, such as their family or employers, to mitigate the risk?
It's a difficult question to ask, isn't it? Was there enough done? I mean, I guess in circumstances there's always more that can be done. I think what we tried to do was to ensure that people who understood themselves or felt themselves to be particularly at risk had access to support. And certainly what increasingly we tried to do was to make data available to people so that they could understand, for example, what the levels of COVID prevalency was in their local communities. So they were able to make their own judgments about what was appropriate for them and how they wished to manage those circumstances.
Well, I suppose you could always say there's always more that you could have done, but it's not really an answer to that question, is it? Just in relation to what more could have been done, do you accept the approach of essentially requiring that the non-shielding at risk people self-refer to local authority help services was insufficient given the heightened risk that they faced?
So I think that it was appropriate for people who felt that they were particularly at risk to make that decision for themselves. I think the inquiries heard from the Chief Medical Officer concerns that the blanket approach that was taken to shielding was not helpful for some people, and that I think there is this. I'm not an expert in these matters, but I do think that there are questions to be asked about whether in future we should take such a blanket approach to people, or whether we should focus on ensuring that people have the information that they need to understand what level of risk they are exposed to and what level of risk they think is appropriate for them.
Wouldn't that approach require a more targeted strategy for contacting those people? Because if you see, the difference is, if you're going to be saying to people, this is you're at risk and it's your choice what to do, and you know that they are at significant risk, isn't it very important that the government, as they did with shielded people, find out who those people are and contact them?
So I would agree that the more targeted we can get, the more helpful that is. And certainly, with the shielded group, we tried to take steps to get more targeted around different clinical conditions, for an example. I think when you start to look at, quite large groups around, for example, people over 70, there is a big difference in terms of the level of fitness and other issues that affect that group. And therefore, I think some form of self-identification is perhaps always going to be necessary in that. We wouldn't necessarily hold all the details to enable that.
You refer in your statement a number of times to an individualised or person-centred approach. What do you mean by that, and how could that be better or more extensively implemented in a future pandemic?
So I think that is absolutely back to this point around ensuring that people are, if you like, equal partners in terms of some of the decisions that are being made, that we are giving people advice and guidance that helps them to make an assessment about what it is that they feel comfortable doing and what they don't feel comfortable doing, and that is accompanied by appropriate support to enable people who do feel that they want to absolutely minimise contact with others, that they're able to be supported to manage their life in that way, whereas others who may be taking account of all the risk factors and indeed the impact on their own mental health by cutting off contact with others are more prepared to take a different approach.
So it's identification, contact, support, so the three sort of pillars of it. Finally, a June 2020 framework for decision making called Shielding: A Way Forward for Scotland described the necessity of developing an evidence base about the virus so that the people who were shielding or had shielded could be provided access to support that can help them make informed choices about their lives and put their choices into practice. Do you think those aims were achieved?
I think that we certainly partially achieved those aims. We certainly continued to provide people on the shielding list with, as I've said already, with information as it related to their own individual health condition. I think it's important also to recognise that we didn't, in June 2020, know everything that we know now about the COVID virus. I'm not sure we know everything there is to be known about the COVID virus right now, but as the COVID virus continued to develop, so as we went through the Omicron wave, and as vaccinations developed, then those things changed as well. I think that we tried to do what we could to make sure that we were providing personalised information, and also that we were making information available to people so that they could understand what was happening in their local community and in their local environment, so what level of risk they would be exposed to, because that varied, again, from period to period.
Thank you.
Thank you very much, Mr. Wagner. Ms. Lamb, I think you've already helped us in relation to yet another module, haven't you? So I'm afraid you know 3 more modules. Okay.
3 in total.
I was going to mention, as I've mentioned to other colleagues, I do understand the burden that this inquiry, and indeed other inquiries, because in Scotland you've not only got a Scottish COVID inquiry, I think you've got other inquiries also putting demands on you. So I am extremely conscious of that, as I've said before. So I'd just like to thank you for all the help you've given so far. And I'm sorry I can't say that I won't be asking you to come back.
Thank you very much.
Thank you, and safe journey back to Scotland.
Thank you.
Very well. Monday the 18th of November at 10:30.
Yes, madam.